Good afternoon to all of you. And today we will be discussing some of the problems, challenges that we face in prenatal and postnatal diagnosis of thalassemias in India. Before we come to the inherited disorders of hemoglobin, we just have a look at normal hemoglobin production, how it takes place. We have the globin chains which form the hemoglobin molecule on two chromosomes. We have the alpha chains on chromosome 16 and the beta-like chains, the beta, gamma, epsilon chains on chromosome 11. And these globin genes produce the various globin chains which combine to form the hemoglobin molecule. So this takes place in normal individuals in a very tightly packed fashion where you have an equal amount of synthesis of alpha and non-alpha chains. When you have a defect or mutation in one of the genes, then that particular chain is either produced at a reduced amount or not at all, and this gives rise to the different types of thalassemias. So during prenatal life, we have hemoglobin F as the major component, and later on there's a transition from fetal to adult hemoglobin. So by the time the child is about 6 months old, we have adult hemoglobin as the major hemoglobin, which is hemoglobin A, and a small amount of hemoglobin A2 made up of alpha and delta chains. Now the thalassemias are a very big group. The common ones among them are the beta thalassemias, the alpha thalassemias, and the delta beta thalassemias, depending on which chain is affected or produced at a reduced rate. Then we have the sickle cell disorders, sickle cell anemia, where you inherit a sickle gene, one from each parent, or a combination of sickle from one parent and beta thalassemia from the other, or sickle hemoglobin from one and another abnormal hemoglobin, hemoglobin D from other, which is also a severe disease. Beta thalassemia can also interact with hemoglobin E to give you E beta thalassemia, with hemoglobin Lepore, and with hemoglobin D. And we have the last group, which is known as the hereditary persistence of fetal hemoglobin, where we have continued production of fetal hemoglobin in adult life. Now it is the beta thalassemias which are a major problem in India. We do not have any registries to know the exact number of patients that are there, but there are several estimates which show that there should be around 100,000 patients in India. And to this load, every year we are adding about anywhere from 8 to 12,000 new cases with major disease. Of these, there are only very few, about maybe 15%, who receive optimum treatment and grow well, while the majority are either infrequently transfused or just have very severe anemia, and many of them die young. So what are the challenges we face in the country? First of all, if you compare India with a small place like Cyprus, where they've been able to bring down or even almost control entirely the birth of new babies, we have a very vast country to cover, where each state, the population of each state equals that of different countries. We have a big population, more than 1.2 billion people, of which about 8.6% are tribal groups. We have a great amount of diversity in terms of ethnic groups, in terms of religion, in terms of culture. All this we have to keep in mind. And a large majority, over 70% of the population, live in rural areas, where there is by and large lack of awareness, and access to medical facilities is not very easy. Now coming to the beta thalassemia carriers, or the heterozygotes, their prevalence is very variable in different groups, going right from 1% to 17%. The average is about 3 to 4%, and this translates to almost 40 million carriers in India. And yet many populations have not been screened, and that is why we need a national thalassemia control program. But we have to remember that almost 1 in every 25 Indians is a carrier of beta thalassemia, which is a very big number. Now there are communities, as I said, with a very high prevalence, and these are some of these communities. In Western India, we have the Sindhis, the Bhanushalis, Lohanas, anywhere from 8 to 17%. Then we have the Buddhists, the Mahars, Muslims, Jains, Patels. And it's not just caste groups, but even some tribal groups, which now show a high prevalence of beta thalassemia. North India, of course, we know that Delhi, Punjab, and all these regions, they have a very high prevalence among the Aroras, Khatris, Jats. And in South India, there's a small group of Jews in Cochin, where the prevalence is almost 16 to 17%. In West Bengal, among the Kayas and Mandols, thalassemia prevalence is almost 10%. And again, we have tribal groups in central India, Madhya Pradesh, Orissa, where thalassemia is common. So earlier, tribal groups were only tested for sickle hemoglobin, and that is why we didn't know what is the prevalence of thalassemia. But now, as more and more screening programs are being undertaken, we know that thalassemia is very prevalent in many tribes as well. The only way to estimate the true burden is to do micromapping, and we try to do this in 2 states, Maharashtra and Gujarat, where if you look at the prevalence in each district and then try and calculate the load, in Maharashtra alone there would be 2.89 million carriers and 588 homozygotes born annually. So between Maharashtra and Gujarat, there would be over 1,000 babies with severe disease born every year, and that is why our estimates of 8 to 12,000 may be slightly underestimated. Now, which is the best time that one should screen to identify these carriers? The ultimate goal of screening is to identify carriers or couples at risk, either before they get married, or before conception, or before they already land up with an affected child. And there are several ways in which this can be done. One of the easiest ways would be to do it in the antenatal clinic where pregnant women come. Majority of them come now, apart from the few which would still have home deliveries. Then we have cascade screening, which means screening of extended family members of a family with an affected child or a carrier child. Then premarital screening is one that is not very acceptable in India because because of stigmatization, people do not wish to reveal their carrier status. You can screen high-risk populations, you can go screen different target groups like school children, college students, and mass screening is again not the most feasible because of the huge population. Now, in this project, under the Jai Vigyan program, a big project was done in 6 states in India a few years back. And one of the problems in antenatal screening was that majority of the pregnant women in public hospitals do not come in the first trimester of pregnancy, that is before 12 weeks. Here we had only 14% who came early, and majority came in the 2nd or 3rd week, when very little can be done if the lady is already pregnant. This shows an example of cascade screening where, starting with one homozygous child, you can go back and look at the family members. Here you can see it's a very large family, and you can identify a large number of heterozygotes, even those who are in the younger age group. So this is also another cost-effective strategy for screening. Coming to the technical approaches that one uses, Nestroft, or the naked eye single tube osmotic fragility test, has been used in many studies in India in the past and even now continues to be used, but it has many inherent problems if used on its own. There are problems of false positives, false negatives. So this is not recommended now unless no other facilities are available. Ideally, one should look at the red cell indices on an automated cell counter or a semi-automated cell counter. You have to see the MCV, MCH, RBC counts, and then go on when required to do the hemoglobin analysis. There are many centers in India now who have the HPLC machines, the BioRad platforms, and capillary electrophoresis is slowly also coming in. So these automated machines can very accurately give you the quantitation of A2, F, or any other hemoglobins at present. If you don't have these facilities, it's still possible to do a hemoglobin electrophoresis, which is much cheaper, on cellulose acetate, or you can do a column chromatography and quantitate A2. So why do we need to precisely diagnose the thalassemias? First, if you suspect clinically, then one has to arrive at an accurate diagnosis. So you need laboratory investigations. Sometimes you have to investigate because there is a hematological problem or abnormality like anemia, microcytosis. You have to identify heterozygotes who are generally asymptomatic for prevention programs, and couples at risk, again, for offering them prenatal diagnosis. And lastly, to identify a defect in the pre-symptomatic phase, that is in the neonatal period. This is mostly done for sickle cell disease. It's important for sickle cell disease, but it can also be done for the thalassemias. So when a case is referred to you, there is a small amount of basic information which you must ask for. How old is the individual? What ethnic group does he or she belong to? Why is the testing being asked for? Is there any clinical presentation? If it's a female, is the lady pregnant? And is there any recent history of blood transfusion? Because these can complicate your results. We just look at a few of the normal reference values. Now, normal adults usually have less than 3.5% A2, and fetal hemoglobin is also usually less than 1. In heterozygous thalassemia carriers, the A2 generally varies from 4 to 8%, and the fetal can be slightly increased. Usually it doesn't go beyond 3%, but it can go from 1 to 5%. In the homozygotes, or affected patients, before they receive any transfusion, their major hemoglobin is adult hemoglobin, hemoglobin A, and they have a small amount of A2. If it's a beta 0, there will be only hemoglobin F, no A. If it's a beta plus, then it has small amount of A. It is difficult often to differentiate between heterozygous delta beta thalassemia from heterozygous HPFH, as well as homozygotes of these conditions, because they have very overlapping phenotypes. So here we have the characteristic features of beta thalassemia carriers: mild microcytic hyperchromic anemia, the MCV is less than 80, MCH less than 27, and the RBC count is usually high compared to the hemoglobin level. RDW is normal, and you may see a few target cells in the peripheral smear. The A2 levels, as I said, generally vary between 4 and 8%. There are different cutoffs, different labs take for normal, but now it is more or less accepted that 3.5 should be taken. Earlier, 3.8, 4% were taken, but many cases were missed, so 3.5 is what is usually taken. And as I said, fetal varies from 1 to 3%. So the hallmark of diagnosis of beta thalassemia carriers is increased hemoglobin A2. Well, these are the basic investigations one does: clinical evaluation of the patient, doing the complete blood count and looking at the peripheral blood smear, reticulocyte count, and then hemoglobin analysis. Often you need to do iron studies because iron deficiency is rampant in India, and even along with the thalassemia, you could sometimes have iron deficiency. So when do you need to do molecular analysis or genotyping? So the need for genotyping arises particularly when you have to identify carriers who present in an atypical way. If a child is transfused, you will need to do a genotyping to arrive at a diagnosis. For prenatal, pre-implantation diagnosis, neonatal diagnosis, for all these, genotyping is needed. And also to see the many complex interactions in the thalassemias between different genes, the alpha, beta, delta, gamma genes, and they lead to variations in presentation, so sometimes you need to look at these interactions. A beta thalassemia heterozygote at most times is asymptomatic, but could present sometimes as a mild thalassemia intermedia, and this often happens if you have additional alpha genes, that is, triplicated alpha genes. As far as a homozygote or a compound heterozygote goes, almost 85–90% of them have a severe transfusion-dependent disorder, but you could still have about 15% who may be milder. And these thalassemia intermedia cases, they could be due to inheritance of a mild beta mutation or co-inheritance of alpha thalassemia or co-inheritance of a determinant which increases the fetal hemoglobin level. So genotyping ultimately helps us in arriving at an accurate diagnosis, assessing what the clinical diversity or severity is, to predict the phenotype, to monitor the disease, and for counseling and prevention. Now this is a classical picture of a beta thalassemia carrier. You have a low MCV, MCH, a high RBC count, and the red circled peak is the hemoglobin A2 peak, which is over here 5.7%. So this is very easy to pick up. One has to differentiate beta thalassemia carriers from iron deficiency and alpha thalassemia, and here you can see I've tabulated what you have to look at. All three of them have reduced MCV and MCH values, but the thalassemias, both beta and alpha, will have high RBC count, while iron deficiency will, along with the hemoglobin, the RBC count will also go down. Again, the RDW is normal in the alpha and beta thalassemia carriers, but it will be high in iron deficiency anemia. The serum iron and ferritin are normal in the thalassemias. They will be reduced in iron deficiency. TIBC will be again normal in the thalassemias and high in iron deficiency. And lastly, it is the A2 which will differentiate between all the three. The A2 is increased in beta thalassemia. It's either normal or reduced in alpha thalassemias, and it will be normal in the, or slightly reduced in iron deficiency as well. There are other hemoglobins which can also on HPLC come out in the same window as hemoglobin A2, and here there are three such examples. One is hemoglobin Lepore. Hemoglobin Lepore, one can, just by looking at the chromatogram, one can diagnose it. It has a very characteristic hump in the A2 peak, and the quantitative level is usually quite low, around 10 to 15%. Hemoglobin E and D Iran are two variants which again come in the same window, but usually hemoglobin E has a lower percentage and D Iran is usually around 40% or a little more. Again, both these D and E can be differentiated by a simple hemoglobin electrophoresis, where hemoglobin E will move with hemoglobin A2 at alkaline pH, while D Iran will move with hemoglobin D. One of the major problems we face in diagnosis is borderline or normal A2 in beta thalassemia carriers. And by borderline it can be anywhere from 3 or 3.3 to 3.9%, which is often seen in heterozygotes, at least now in even 1 to 2% or even going up to 3% of heterozygotes. Most often this is due to mutations in the beta promoter or the cap site, like the cap site and the -88, or in the poly-A tail region. But more and more cases are now being seen where you have borderline A2 even with common and severe mutations like the IVS15, codon 15 and codon 13 mutations. You could also see this if heterozygotes have associated delta gene mutations, then A2 can be reduced very much, and alpha gene triplication. So here we see an example where you have a couple. The father is the classical thalassemia trait, and the mother was not, has been, and only the blood count was done, which showed a normal, absolutely normal MCV, absolutely normal MCH. Because she had lost 2 children at 9 years and 4 years of age, didn't have any reports, but she said they had hepatosplenomegaly and had been transfused a few times. We went on to do the A2 and F, and the A2 was very borderline, 3.6%. And we know when we get such a blood picture, the first mutation one looks for, the defect one looks for, is the cap site mutation, and this case had the cap site mutation. This is another example where mutation in the delta gene will complicate the diagnosis of beta thalassemia heterozygosity. Again, here very classical thalassemic indices, MCH, MCV are reduced. A2 is absolutely normal, 2.4%. So looking at such a blood picture, the first thing you might think of is maybe there is an alpha thalassemia. So you do the alpha genotyping. In this case, the alpha genotype is absolutely normal. And that is why we then went on to look at the beta gene, and this person had the common IVS15 mutation. And because generally the IVS15 should not give you an A2 of 2.5, we then looked at the delta gene, and you see that there is an associated delta gene mutation also. So these, if you have a couple with one partner like this, you are surely going to miss them unless you are very careful and investigate them. A classical homozygote is easy to identify. The hemoglobin is low, and most of the hemoglobin you see on the HPLC will be hemoglobin F. So this is not difficult. There are many genetic interactions that can take place which alters the severity of the disease. For example, in homozygotes and compound heterozygotes, for the severe cases, if you inherit 2 mild beta plus mutations, you could have a milder disease. You could inherit 1 severe and 1 silent mutation. Again, that will give you a milder disease. You could co-inherit alpha thalassemia, which will alter the severity. Sometimes a single alpha gene deletion may not cause so much of a problem. And you could have some gene which enhances fetal hemoglobin production. The XMN1 polymorphism has been studied very widely in India, and if the XMN1 is ++, fetal hemoglobins can be slightly higher. But now we know that there are many other genes, there are promoters in the beta globin, and there are many other genes which are also involved in regulating fetal hemoglobin production. So one has to, they are known as, there are the quantitative trait loci on different chromosomes, and more people are now looking at these and seeing how they can be modulated to alter the severity of the disease. Now coming to the carriers who are generally asymptomatic can also sometimes present as thalassemia intermedias, and often this is because of extra alpha genes. Sometimes due to presence of a single mutation but a dominant mutation which is present usually in the 3rd exon of the beta globin gene. The ETHealthworld, they have a very wide spectrum, clinical spectrum, so they could be mild, they could be severe. And if you co-inherit deletions for delta beta, hemoglobin lipoor, or HPFH with beta thalassemia, again they have a wide spectrum. So this is an example of interaction of alpha gene triplication leading to a thalassemia intermedia presentation. This lady, she always has a hemoglobin between 7 and 8 grams. Although her indices are low, she has a typically raised A2. And you can see here, along with the severe beta thalassemia mutation IVS15, she has an additional alpha gene. So such cases are often seen, and they can present as a thalassemia intermedia picture. Alpha thalassemia, now coming to alpha thalassemia, it is very common in India, but we don't have the severe varieties. In the caste population, the prevalence of alpha thalassemia anywhere from 3 to 23% in different groups. In tribal groups, it's very high. It can range from 17 to 97% in some tribal groups in South Gujarat. It's almost everybody has an alpha thalassemia defect. But the common defect that we see is a single alpha gene deletion, and that does not cause much problem. We also see 1 to 2% of cases who have a triplicated alpha gene. And few cases of hemoglobin H disease, which are generally due to a defect in 3 of the alpha genes, are reported from time to time. Hemoglobin H disease must be looked at carefully for diagnosis in the lab. Usually on HPLC, you see a sharp spike at the start of the chromatogram, which is not read and shown as hemoglobin H or as alpha thalassemia. But if you do a classical electrophoresis, you will see that a fast-moving band is seen at alkaline pH. And when you do the reticulocyte staining, you will see inclusion bodies which have a golf ball-like appearance. And these are all indications of the presence of hemoglobin H. Now coming to the control programs, we need some basic information, we need accurate demographic data, we need to intensify our education programs, awareness programs, and we have to develop services which can reach everyone. We also need adequate facilities for counseling and prenatal diagnosis. So the very good programs that we have for awareness and screening are in Gujarat and West Bengal. They can be used as model programs to develop in other cities or in other states. In West Bengal, they've taken 2 nodal centers, 2 medical colleges, and under that they have different districts. So they have been able to cover the whole state almost. Gujarat also is now trying to spread out to other areas. So these examples can be used to develop prevention programs and screening awareness programs in other states as well. So what are the reproductive options that couples at risk have? First and the most commonly used one is the conventional prenatal diagnosis. There is a possibility of non-invasive prenatal diagnosis. Few cases have been tried by a couple of centers in India, but still at an experimental stage. For the thalassemias, it's not being used routinely, but soon it will come in when you won't need to do any intervention procedures, invasive procedures, and just from a mother's peripheral blood sample, you may be able to do a diagnosis. And the third is pre-implantation genetic diagnosis. This is not a replacement for the conventional diagnosis, but it's just an additional option, particularly for those couples who do not wish to terminate an affected pregnancy or who've had a particularly bad obstetric history, they've had repeated homozygous children, then they can go in for this option. But it is expensive. It requires expertise and a very good genetic lab who can generally diagnose at a single cell level, and of course expertise in vitro fertilization, which is there in the country. So we talk about conventional prenatal diagnosis. Here you need expertise for fetal tissue and fetal blood sampling. The CVS is usually done between 10 and 12 weeks of pregnancy, but it can be done up to 14 weeks. Before 12 weeks, we don't do it usually. Amniocentesis at 15 weeks if the couple comes late, and if they come even later, you can still do a portocentesis at 18 weeks and do a fetal blood analysis. So why do most countries have switched over from second to first trimester diagnosis? Why is it in India we still continue along with first trimester, we still have to continue second trimester, although prenatal diagnosis is going on now for almost 25 years in the country. Mainly, it is because of the limited awareness, because couples don't come early or women don't come to the antenatal clinics early. Often they just come from their villages, they come and register with some lady or mother or mother-in-law, and the husbands don't come along with them, so it's difficult to get the husbands. And occasionally the mutation may remain unidentified. So creating awareness is the key to a successful program. You can do it for many groups. You can do schools and college students, high-risk communities. It is also important that medical professionals, particularly obstetricians, pediatricians, family physicians, they should all be aware. Policy makers and political leaders, of course, without their support, it cannot be done. Program in a country like ours. And lastly, the general public. We have in India in each state there are NGO groups who are working on creating awareness and undertaking screening programs, and there are also thalassemia societies comprising of patients and parents who are playing a major role in these programs. Now this is again from the Jai Vigyan project, which was done in 6 states in a big way, and at that time the knowledge of thalassemia was very limited among college students and virtually non-existent among pregnant women. After this, of course, in the last 4 to 5 years, a lot of awareness has been generated, and I said earlier, West Bengal and Gujarat have done things in a big way. A couple, particularly coming from a rural area, has to be very carefully explained what is the inheritance of thalassemia, that when 2 carriers get married in every pregnancy, there is a 25% risk of having an affected child, a 50% risk of having a carrier child, and a 25% risk of having a normal child. Very often they don't understand this, and they feel that if they've had one affected child, other children will be normal. Now, coming to counseling couples for prenatal diagnosis, there are some genetic combinations which do not require prenatal diagnosis, and it's important to remember these because sometimes a couple is sent over long distances and we have to send them back saying that they don't need this at all. So if you have a carrier of beta thalassemia in one parent and the other one is a D Punjab trait or a Q India trait or an HPFH trait, you do not require prenatal diagnosis because the disease is very mild. Even for homozygosity of hemoglobin E or D Punjab or HPFH, this is not recommended. And what you see on the left is the other conditions where prenatal diagnosis should be done or should be advised. We now have a very good idea of the mutations seen in different regions of the country. The blue bar, the IVS15, stands out as the most common mutation in every region, except among the immigrant population from Pakistan, where the 619, the red bar, is higher. And in each state or each region, apart from 7 common mutations which account for about 80 to 85% of the molecular defects, you have mutations. We now know in India more than 70 mutations have been described. In fact, almost 80 mutations have been described. And occasionally it becomes difficult to identify them and you have to directly go for a DNA sequencing. So this is the approach for diagnosis that is usually used. You do either an allele-specific amplification like ARMS or a reverse dot blot hybridization where you can look at several mutations in one step. And after that, if the mutation doesn't get identified, you can go and do a DNA sequencing. This is what is done in the first trimester after chorion villus sampling and DNA analysis. If the couple comes late, you can still do at 18 weeks or 19 weeks a fetal blood analysis. You have to first stain the fetal cells which are withdrawn from the fetus to check that there is no maternal contamination, and this can be done very easily by a simple Kleihauer-Bethke staining. You should not see a single ghost cell. All the cells should be faintly stained. Only then can you use the sample to do an HPLC analysis. And here you see this is a homozygous fetus because you only see one large peak of fetal hemoglobin. There is no hemoglobin A present. But this can be done just in a few minutes, and in such a situation you can give a diagnosis very quickly. Even if they come at 18 weeks, on the same day you can do a diagnosis. Our main nightmare in counseling and prenatal intervention is the atypical heterozygotes, where one partner is a classical beta thalassemia carrier, diagnosed very easily, but the other partner has reduced or near normal MCV and MCH, has a high RBC count, but near normal or reduced hemoglobin A2 levels, and a normal hemoglobin F. In such a situation, we have to rule out the following. We have to see whether there is any silent beta thalassemia trait, a silent mutation, if there is alpha thalassemia trait, if there's co-inheritance of beta thalassemia with alpha thalassemia. A delta thalassemia trait on its own can also reduce A2. Mostly if you have a delta defect, the A2 levels are less than 2%. You could have a beta thalassemia trait with a delta thalassemia trait, and here also in majority of these cases, the A2 levels turn out to be normal. This is something people were not looking at earlier, but now we know that if it is a couple, you must, where one partner has a normal A2, you must look at the delta gene. And all these investigations can be done at several of the centers, expert centers we have for prenatal diagnosis in India. We have about 15 centers in different states. The Indian Council of Medical Research has also recently developed new centers, one in Ludhiana, one in Nagpur, one in Bangalore, one in Surat. But we need many more centers. These are not going to be enough to cover the whole country. We can't expect couples to keep traveling long distances to come to reach a diagnostic center. So what are the challenges, the major challenges in the control of thalassemias in India? First, and the major problem is ignorance and lack of awareness. If this happens in a big way, a lot of our problems will get solved. Secondly, the blood count is not done or not correctly interpreted during the first antenatal visit. Often only the hemoglobin gets done, but it's very important that the whole CBC should be done, and somebody should interpret the CBC correctly and advise for hemoglobin analysis. Because often couples then come very late when nothing can be done. There are many other practical problems, not only in rural areas, but also in urban areas where you could have equipment which is lying non-functioning for long, it's not maintained properly, reagents supply is not regular. So these are all practical problems that each center would face from time to time. We have a lack of adequate trained obstetricians or sonologists for fetal tissue and fetal blood sampling in rural areas, and this is because due to this, couples have to travel long distances to reach a diagnostic center. And lastly, it is difficult for many couples to, even if they want to have a prenatal diagnosis done, that option is open to them. They have to decide whether they want to do it or not, but they cannot reach a center. So lastly, in our present situation, there is an inequality in the available services, both for management and prevention of thalassemias, between rural and urban areas. And ultimately, we have to see that all the services become available to everyone. And the only way that this can happen, and is starting to happen slowly, is if we integrate thalassemia management and prevention programs in the public health infrastructure and the public health programs. The country is planning a national thalassemia control program or hemoglobinopathy control program, which hopefully should take off the ground soon, and screening, awareness, counseling, and prevention will become available, as well as management of the existing patients in every state, even in rural areas. Thank you very much for joining in. we come to the questions. The first question is by Rashmi Mabian. How much are the screening programs being enforced in India? As I mentioned in my talk, screening programs are going on in every state. It is West Bengal and Gujarat have done it in a very big way for thalassemia, but other states are also doing it. Delhi has a good program. There are several, every state has a program, but it has to be amplified and done in a much bigger way. I can't hear the question. Hello?
So the next question is from Dr. Amit, and he wants to know, how do you see the Indian scenario in thalassemia after 10 years? Hello? Hello? Hello?
I can't hear any more questions. Now the next question is by Aditya Kumar. How do you see the Indian scenario in thalassemia after 10 years? Well, I'm sure in another 10 years we are going to go ahead and certainly have a national program, and we'll have registries, we'll have better opportunities for management of patients in all areas. So we are already progressing, and certainly we should be going ahead and having a national program. The next question is by Dr. Noor Jahanul. What will the level of hemoglobin A2 if patient of beta thalassemia trait is associated with alpha triplication? Sometimes if alpha triplication is there, the level of A2 can be reduced, but not necessarily. We mostly don't see a low level with triplication, but this can happen sometimes. There is one more question. What is the annual treatment cost for a normal weight child with thalassemia? Again by Rashmi Mabian. Well, the annual treatment is anywhere from 1.5 to 2 lakhs for a child, and this might go up as the child grows older and has complications, you have more tests to be done, but generally it would vary between 1.5 and 2 lakhs. Again by Dr. Noor. Then how to diagnose carrier state in that case, madam? Well, you should refer, if it's a couple where one partner is a classical carrier, I told you, you should rule out all other possibilities. So if you don't have the facilities to do that, you should refer them to another center where all this is possible to do, especially if the lady is pregnant.
Thank you, Dr. Colah, for taking this webinar session on the problems in prenatal and postnatal diagnosis of thalassemias. Attendants can send us their questions at editor@ETHealthworld.com. It was an engaging and insightful talk, and we hope all the participants have enjoyed the session. The recording of this webinar will be made available on ETHealthworld.com by tomorrow. Thank you everyone for joining this webinar.